Welcome to the Cardio Ohio podcast, a production of the Ohio chapter of the American College of Cardiology. This is Kenny Graywall in Columbus, Ohio.
This is Ben Allencherry, Cardiovascular Imaging Fellow from Cleveland, Ohio. More information on the podcast, including past episodes, is available at ohioacc.org.
And now for today's episode. So welcome back to the Cardio Ohio podcast. This is Kenny Graywall here in Columbus. Unfortunately, my partner in crime, Ben Allencherry, is actually preoccupied with actual patient care tonight, so is unable to join us. But I am very happy to announce our guest. I'd like to welcome Dr. Phil Barger. He's an adult cardiologist in Cleveland. He's the director of the Adult Congenital Heart Disease Program at University Hospitals of Cleveland, and he's clinical professor at Case Western School of Medicine. Phil, welcome to our program.
Thanks, Kenny. Great to be here.
We thought we would just spend the next 25 minutes talking about your perspectives that you can give to us in the world of adult cardiology about this patient population, which can be very complex, can often follow longitudinally. I thought I would start just by asking a little bit about your path to becoming an adult cardiologist who focuses on this population, what led you into that specialty, and what brought you to Cleveland, which is, by the way, my alma mater as well.
So that might be a longer answer than the podcast can handle, but I didn't go into cardiology planning on specializing in adult congenital. I grew up in Ohio, med school at Case Western, did internal medicine at the University Hospitals, and then went to WashU in St. Louis for adult cardiology. And I sort of had two pathways while I was there. I had a basic science pathway, and we were looking at molecular mechanisms responsible for changes in fatty acid metabolism. And we were closely linked to a pediatric cardiology lab run by Arnie Strauss, who was chief of peds cardiology at the time. And then during my second clinical year, my continuity clinic, I asked to be assigned to the adult congenital heart disease clinic that had been in existence for only a couple of years at that. This was back in the 1990s. And this all preceded any ACGME accredited fellowships. For a number of years, there were several institutions that had sort of off the books fellowships where you could go spend a year and sort of get exposure to ACHD. And I simply came about mine by doing it in my continuity clinic. And then I continued that as my clinical niche for my first faculty appointment. And then continued to do that since that time. Spent some time in Houston after St. Louis at Baylor College of Medicine and Texas Children's Hospital and the great folks there. And then went back to WashU and continued the ACHD. And ultimately that became my academic and career focus. The beauty of academic medicine is that you can reinvent yourself several times over the course of your career. So anyway, when the job in Cleveland came open, it was sort of a full circle for us to come back home and try to grow a program at the University Hospitals. And part of the attraction, I guess, is that actually stems from probably my science background, which is, in science, although we have sort of rules and laws that we think are immutable, you really are allowed to challenge every single assumption that's out there. And adult congenital cardiology is sort of the same way. We don't have, even though we've got a 180-page set of guidelines, in all of those guidelines, there is a single recommendation that's level of evidence A. Everything else is something else, which means that we just don't have great data. And so we really have to challenge ourselves to think about each individual patient on a very individual level and understand their unique physiology. And so it's a lot of fun because we don't have to follow any rules because there aren't any. So I think that's sort of how my bent towards science and curiosity ultimately morphed into adult congenital heart disease.
I'm just curious, with your background and training in adult cardiology, how has your experience been there working in a pediatric hospital in terms of just what you've learned since you joined there and how you integrate with the rest of the team there?
Well, it's it's been culture shock, I think, for both sides. Pediatric cardiology in general, right, approaches things a little differently than adult cardiologists, though there are some similarities. I mean, peds cardiology probably pioneered the concept of sort of a heart team approach, but really is basically the entire division of pediatric cardiology and pediatric CT surgery getting together to discuss on a regular basis. And, in the adult cardiology world, although the heart team approach is being used more often for complex cases, we've become pretty comfortable sort of identifying the problems and reaching out to appropriate colleagues who have the expertise to address those. So that's been fun for me, right? Participating in those sorts of discussions. And there's a lot of, I see the end result of congenital heart disease palliation. These patients, and so these patients are not cured as kids, right? So in most cases, they've been palliated and there are long-term consequences, many of which don't show themselves during childhood. So I'm interested in looking for things that happen later and perhaps aren't seen as frequently in the pediatric world. There's certainly some surgeries that have been performed that are common, right? In my clinic, that pediatric cardiology fellows never see, right, in kids, and only see those surgeries either in a textbook or if they come to my clinic. And for instance, the so-called atrial switch for detransposition of the great arteries. So there's a more modern surgery that's typically performed now, the arterial switch or the so-called Jatine. And that's the other thing. We've named all of our surgeries and procedures after people so that we can have a super secret club that only we know what we're talking about.
So your situation is unique in that you work directly with a pediatric cardiology team. But in that setting, when do you typically pick up a patient? Is it based purely on age or is it based on physiology or some other stage of their condition?
It's mostly based on age. So at least as patients approach age 18, that's just sort of our random number, right? The pediatric cardiologist begins to think about and discussing with the patient and their parents or caregivers, ultimately transitioning to an adult cardiologist, presumably an adult congenital specialist, since I'm embedded within that system. So they begin those discussions. And at a point when they think that the patient and family is sort of emotionally ready and has the maturity to make that transition. And many centers have different approaches to this. The one that we have recently started employing, I have a nurse practitioner that works with me. And so what she will do is once we learn that the patient is felt to be ready to transition, she sets up a virtual clinic visit with the patient and their family. So the patient can be in their own home. They don't have to come to sort of a new clinic area when they're meeting the new doctor. And that virtual visit is really kind of both an educational visit and a get to know you visit. So we ask the patient, what do they like to be called? What are their biggest fears about their disease? What do they know about their disease, their anatomy? What do they know about their surgeries or procedures? And this is usually set up perhaps 3 months before they might be scheduled to see me on some sort of regular follow-up. So it's a pretty easy process to get the patient from pediatric provider to ACHD provider. In many places, that may not be the case. And when I was at WashU, I was embedded in adult cardiology. And there wasn't a great link between the last pediatric cardiology visit and the first ACHD visit. And so we're hoping that we have been able to sort of fill this gap with the virtual visit, but we got to learn that the patient exists. And so that's always been a real risk in this field, is that frequently the patient themselves want to believe that they were cured and not just as a kid, and they feel okay, right? A lot of these long-term consequences to their surgeries or procedures may not start to show up in a symptomatic way until after they've passed their 18th birthday. And so either they leave home and don't arrange for a new cardiologist, or they go off to college and sort of don't want to think about it. And many times, this is my past experience, they represent perhaps in their mid to late 20s, when all of a sudden they are significantly symptomatic. And in some cases, we've missed the window to intervene on the disease process to get the best outcome. So trying to catch those patients right as they turn 18. So 18 is sort of our number, but there are situations, for instance, if patients become pregnant right before they turn 18 and the pediatric provider is not comfortable taking care of a pregnant teenager, we have experience with ACHD in pregnancy. And so I'm happy to see younger patients. If they're doing adult things, they're probably ready to come to ACHD clinic. So that's generally how it happens, at least as far as sort of transition by age. But there are some situations that congenital heart disease patients are incredibly attached to their cardiologist. And so if they've been seeing the same pediatric cardiologist for 18 years, it's really quite emotionally traumatic for them to switch cardiologists. But sometimes these patients really don't transition until they're much older. Many of them have had sort of multiple open heart surgeries, right? They've been on cardiopulmonary bypass multiple times, and they end up with some cognitive delay or developmental delay. And so they're more dependent on parents and caregivers. So sometimes I do catch patients that are much older than 18 that are still coming from pediatric providers.
Sure. When you're talking about patients with complex disease who've had surgery, I think they clearly may have a little smoother transition to a clinic like yours. But for those of us out in practice in adult cardiology, of course, we see kind of the spectrum. We see the patients with milder disease who maybe never needed an intervention, bicuspid aortic valve or aortopathy. And like you said, in my experience anyways, so many of them, because they're young adults who feel good, they're moving between college and other locations. They may not have a smooth transition with health insurance. They kind of put it on the back burner and then they surface, just like you mentioned. What are some tips you have for adult cardiologists who may see a patient at a little bit later age, 30 years old or later, as far as that initial assessment? Is it really assessing functional capacity? Do you go straight to imaging, et cetera? Like, what are some of the things you would focus on when a patient like that kind of reemerges and now is going to maybe need some serial care?
Yeah, I mean, we do a lot of serial imaging on our patients, certainly on a regular basis for everything that's sort of in the moderate to complex congenital heart disease. If you look at the guidelines, the ACHD guidelines, there's sort of three categories. There's simple lesions, there's moderate lesions, and which is the majority of the lesions, and then the complex ones. I think in many cases, the moderate and complex lesions need some regular imaging. In some cases, the very simple lesions may not, right? A patent ductus arteriosus that's been surgically ligated and early so that there was not dysfunction or pulmonary hypertension, and it's been proven in the past that it's no longer patent. They probably don't need any regular imaging or follow-up, and there may not be any sort of long-term sequelae to that. But even for a surgical atrial septal defect closure, I mean, there's a very small subset of patients that may present later with some degree of pulmonary hypertension. And they may not be symptomatic from it, and only imaging is going to reveal that to you. So I think if they haven't had imaging, if they show up in your office, right, for the first time, and they haven't had imaging in a while, right, even for some of the simple and less complex moderate lesions, they probably do need an echo and then you can go from there depending on what you're trying to tease out, right? These patients do learn to accommodate to their limitations. And so I think they truly believe in many cases that they are not symptomatic. And in for certain lesions, right, the development of symptoms is part of the decision-making process of when to either go to more invasive type imaging or even begin to plan for sort of reintervention, whether it's surgery or catheter based. And so they may tell you that they're not symptomatic. And so then you may need functional assessment, like via CPAT to sort of help sort it out. And perhaps even, I've used that trick in the past where I'll tell a patient, look, it's important for me to know whether you're symptomatic or not. You say you're not, but turns out you really don't push yourself, right, to do anything where we could figure that out. And so then I'll tell them what their sort of predicted VO2 max should be for their age and gender, and then we go do a CPET, and they come back with a number that's significantly less, which is usually the case for congenital heart disease patients. So it's a bit of a trick because I know what I'm going to get, and then I can say, look, you do have limitations that you just don't realize because they've learned to accommodate to those things. So sometimes you have to do a functional assessment to get a sense of
Sure.
whether
Sure.
they're limited or not.
That's interesting. We do the same thing with elderly patients with valvular disease when we don't necessarily trust their symptoms. We have to do a functional test to confirm if it's significant or not. So I guess it's a very similar approach.
Yep.
So I know as these patients go through adulthood, I mean, is it fair to say that probably heart failure and arrhythmias are kind of the two areas of complications that may eventually set in, even if they originally did have corrective or palliative surgery? So I was just curious for our listeners, if you have any tips on we can take both one at a time, but say for heart failure, is there any tips in terms of how that presents in this patient population versus the adults we're used to?
In my mind, it's really not any different. I mean, I think there's some situations, for instance, single ventricle patients or sort of Fontan palliated patients. They probably all are some version of heart failure because they have a very high central venous pressure, high Fontan pressures based on their physiology. So for them, they're sort of always in this sort of chronic heart failure state, even if they have preserved systolic function of their single ventricle. But for everybody else, it's the usual stuff, right? So whether their systemic ventricle is anatomically an LV or an RV, when they get heart failure, it's going to look the same, right? They're going to have elevated neck veins or CVP. They get edema. They get abdominal distension. They have exertional symptoms, et cetera, et cetera. I mean, it's obviously tougher if you have a systemic right ventricle just based on echo alone to figure out what the RVEF is and then how to do decision making based on what you know about the left ventricular ejection fraction and timing for interventions. So sometimes additional advanced imaging is needed, right? Like a cardiac MRI to get better assessment of biventricular function and things like that. So, but I think from a symptom standpoint, it's pretty much the same. Now there could be heart failure mimics. And again, I think about the most complex patients, right? The single ventricle Fontan patients can get terrible lymphedema or a massive lymphedema of their lower extremities. And so, again, it's impossible to sort of gyrese it off, even if they are massively total body volume overloaded. So those could be tricky patients to take care of. But I think if somebody like that comes into your office, you're gonna be like, okay, I have to find however far away they are, the closest adult congenital heart disease specialist and arrange for a consultation. And we're more than happy. I mean, when I was in St. Louis, I mean, I had patients that lived 4 to 6 hours away from St. Louis. They sort of all came to St. Louis. So we're happy to sort of co-manage these patients if they don't live close to where we have our ACHD practice. So we don't have a lot of data. I mean, for managing heart failure, right? There's really very limited data on efficacy of a guideline-directed medical therapy for instance, for systemic right ventricles or even for single ventricles. But so the stuff that we do is in many ways off label, but I apply what we all know as adult cardiologists for managing LV dysfunction for a systemic LV to all my other patients, and in many cases have success with the same medications. But from a heart failure standpoint, I think we know it when we see it, and you can apply some of the same things that you know to what I refer to as conventional anatomy. I tell my patients they have alternative anatomy as opposed to using terms like normal and something other than normal, right?
In terms of arrhythmias, obviously we don't have time to get into all the nuances, but do you generally, in an adult, rely on symptoms before you investigate? Is there any role for screening, or say, are you using more of the implantable recorders like we're using in the adult with de novo arrhythmias?
Well, I would say that we do all of the above. So over 50% of adult congenital heart disease patients have some form of arrhythmia. So it's hugely common, and it's important even for me as a ACHD specialist to have an EP colleague, right, who has a comfort and familiarity with ACHD to talk things over. So sometimes we're just waiting on symptoms, right? We know that everybody's at high risk, and so we're sort of looking to sniff out symptoms. So I don't, necessarily put Holters or Zios on everybody, but in some cases there is a propensity for certain rhythms that lead to sudden cardiac death. And so we may, and they can be supraventricular. A fast conducted flutter in a single ventricle patient can lead to sudden cardiac death. So some cases where if we even get a little sniff of, well, I sort of have these dizzy spells, or I don't know, maybe I had a palpitation. We're sort of looking for those things. And then the tetralogy of Fallot patients who had the sort of old school approach to the repair, not what's done in kids today, but what was done in adults, even as recently as 30 years ago, they end up with a big RVOT scar that's a nidus for VT. In some cases, we might be covering that up if we're sending them for instance, for a transcatheter pulmonary valve. And so I may send them for an EP stem study to make sure that we can't induce any VT from that area before somebody puts a stent in there prior to placing, for instance, a Melody valve or a Sapien valve inside that stent. So sometimes we go sniffing for it. We're always on the lookout. And for many of these patients, particularly the systemic right ventricles and the single ventricle patients, they poorly tolerate even SVTs. So they may be feeling sick and you may not understand why, because they may not sense palpitations, but something's off. And so arrhythmia is always at the top of our list as to what may have thrown their physiology out of whack.
That's helpful to know. So just to wrap up in our last couple minutes here, you kind of hinted at the fact that you do co-manage some patients with local cardiologists. And I think there's so many specialized diseases in cardiovascular areas where we do need to have a partnership between kind of the frontline cardiac provider and specialists at institutions like yours. Would you say that's still a minority of your patients? Or do you see that growing in terms of patients that you may just see once a year and then you rely on a local practitioner to kind of handle the day-to-day needs? And how do you just kind of organize the communication and that co-management?
I actually leave it up in many cases to the primary cardiologist. I mean, although I collect a number of patients, right, that transition directly from pediatric cardiology, as we discussed earlier, probably the majority of patients, though, that are coming to see me are either already currently seeing a general cardiologist or have seen general cardiologists in the past. And so if they've got a relationship, or even perhaps a long-time relationship with the general cardiologist, and now I open, a new clinic in Cleveland, and they live, I don't know, in Sandusky, right? I am very happy to co-manage those patients and have discussions as needed with the primary cardiologist. So I'd say it's fairly frequent because, again, these patients do become attached to their cardiologist, right? They see, and there's something magical about the heart, right? And this is something that they've been focused on since they were tiny in most cases. And sometimes that's a general cardiologist in the community. And I don't want to disrupt that relationship, because trust in sort of what we recommend and how we're approaching their particular situation is really important. And so if I can have a conversation with the general cardiologist and they trust their general cardiologist who says, yeah, let's go along with the plan, then it's a win for everybody. Now, if the general cardiologist is like, well, I've seen them one time and I really think they should follow with you, then we're happy to do that. But even then, right, if they're 2 hours away and it's not easy for them to sort of come back to main campus Cleveland, then it really is important to have a local cardiologist that can be my partner, or I can be their partner in managing these patients.
I guess one thing we're blessed with here in Ohio is that we really have a lot of excellent tertiary care institutions in every corner of the
Yes,
state.
agreed.
But there are still more CHD patients statewide than there are specialists like yourself. So we definitely appreciate you as a resource, and others all around Ohio. But any final thoughts for our audience about anything we can do better to kind of improve outcomes in this group of challenging patients?
Well, just a couple. I'll just make a few statements here. We do know, based on some old data now, right, and again, this reflects co-management, but if a CHD patient is getting at least a component of their care, right, at a CHD center, the data suggests that they have less morbidity, right, and improved mortality over the long term. So I think it is good to at least get perhaps at least a single consultation in many cases for your patients at a CHD center. This is a population that's growing. So I think the latest numbers are something like 2.4 million adults with CHD in this country. And there's twice as many adults with congenital heart disease as there are kids. And that number continues to grow because of the excellent survival. At this point, greater than 90%, and in some series up to 95% of kids born with congenital heart disease, right, live to adulthood and beyond, right? And so their numbers keep growing. So when we talked about heart failure and cool name surgeries and all of that. So that's always my hook for the fellows. And as they think about sort of what they want to do with their careers, but you get a little bit of everything in adult congenital, including, in many cases, young patients, right? So you get young patients, you get EP, you get heart failure, you get some pretty cool anatomy and physiology that you don't see anywhere else, and without a lot of roles. So it provides sort of ongoing stimulation and challenges to us. So PhD.
Well, thank you so much, Phil. Before we sign off, I do want to remind the audience that the ACC guidelines for adults with congenital heart disease were put out in 2019. It's an excellent document. I've just been reviewing it recently. It has the nice classification system that you alluded to and lots of other details. So we'll be putting a link to that in our notes for today's session. So thanks so much, Phil. Thanks for your care in this population, and thanks for educating the rest of us in adult cardiology as well. And we look forward to your insight on future topics.
Thanks, Canny. Happy to be here.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.